Today's material is a comprehensive guide on local anesthetics in dentistry, detailing administration methods, adverse effects, and dosage calculations, which the author intends to deliver as an educational lecture.
Yeah.
And, I mean, imagine giving a 10-year-old child a standard dose of anesthetic only to realize you've just administered a fatal overdose because you mentally treated them like a small adult.
Right. Exactly.
So, a key theme running through this material seems to be the sheer depth of clinical information presented, which is designed to prevent exactly that kind of nightmare scenario.
It really is.
The author has compiled this incredibly robust reference text here. I mean, it covers everything from microscopic mechanisms of regional blocks to the precise pharmacological properties of various preparations.
Yeah, it's dense.
Highly factual. If I'm a practitioner, this is the exact text I want sitting on my shelf. But today, we're looking at how to translate this into a live lecture, which brings a completely different set of challenges.
Transforming comprehensive reference tables into an engaging lecture requires sequencing the information around clinical decision-making rather than simple categorization.
Wait, I want to stop you right there. Because looking at the source material, specifically that section titled Choosing a Local Anesthetic, I actually thought the organization made a lot of logical sense.
Oh, really?
Yeah, the author heavily relies on Table 13.8, and this table organizes the drugs strictly by their duration of action. So, you have shorter-acting, intermediate-acting, and long-acting preparations.
Uh-huh.
Then it subdivides them by the presence or absence of vasoconstrictors like adrenaline or felipressin. As someone trying to mentally map out all these drugs, isn't duration the most fundamental way to categorize them?
Well, from a purely taxonomical standpoint, absolutely. The weakness here isn't the accuracy of the data. It's the format of the delivery.
Okay.
This structure is absolutely perfect for a written reference manual. Something a dentist keeps in their desk drawer to quickly verify a contraindication between patients.
Right.
But simply reciting these categories in a live lecture format will inevitably cause rapid cognitive overload. I mean, if you just stand at a podium and read down the list, lidocaine, mepivacaine, prolicaine.
Articaine? Bupivacaine? Yeah.
Exactly. The audience's eyes are going to glaze over within 90 seconds. When students passively receive data without any immediate, high-stakes context for how to use it, they just disengage.
They assume they can just memorize the table later for the exam.
Precisely.
Which means you've lost them in the room entirely.
So the suggestion is to completely upend that traditional textbook structure.
Yes.
Instead of presenting the data as a flat taxonomy, you're saying the lecturer should introduce these anesthetic choices through realistic patient profiles.
Yeah, exactly that.
You essentially want to force the audience to apply the knowledge in real time, making them pull the necessary pharmacological data out of the clinical scenario rather than handing them the data first. You have to make the information a solution to a problem they actively care about. Let's look at some concrete examples of how to actually execute this on stage.
Okay, walk me through it.
Instead of simply putting up a slide that lists the properties of felipressin and clinically noting that it's a vasoconstrictor alternative to adrenaline, you present a dilemma.
A clinical dilemma.
Right. You tell the audience you have a pregnant patient in the chair needing routine restorative work. You need an intermediate-acting anesthetic.
Okay.
Why should you reach for felipressin with prilocaine instead of a standard lidocaine with adrenaline?
Oh, wow. Right, and that immediately creates a puzzle. You aren't just telling them a fact. You're asking them to be the doctor.
Exactly.
But if we focus entirely on case studies, is there a risk that focusing solely on the clinical hook might overlook the underlying pharmacological rules, like why felipressin has minimal effects on the myocardium at 0.03 international units per ml compared to adrenaline?
That makes sense. But could the evidence also support a different conclusion? Like the clinical hook actually reinforcing the pharmacology?
How so?
Well, the case study is merely the hook, right? The pharmacology is the payoff. Once a student is professionally invested in not harming that hypothetical pregnant patient, those dry pharmacological facts suddenly become intensely relevant.
Ah, I see. You don't skip the science.
No, you use the scenario to create a knowledge gap that the science fills. So, right after you pose that question about the pregnant patient, you dive into the why.
The receptor science.
on adrenergic receptors in the heart, which increases cardiac output and heart rate. Felipressin, on the other hand, is a synthetic analog of vasopressin.
Right.
It primarily acts on V1 receptors in the venous microcirculation, not the arterial side. And it has almost zero direct effect on the adrenergic receptors of the myocardium.
And that's why, at that specific concentration, it doesn't trigger the cardiac spike that adrenaline does. That makes total sense. You're grounding the microscopic receptor science in a macroscopic human problem.
Exactly. And you can do the exact same thing with bupivacaine. Instead of just reading the slide bullet point that says, do not use in children younger than 12 years.
Which is easy to forget.
Super easy. Instead, you put the audience in the hot seat. You say, you have a 10-year-old child in the chair requiring a long, complex procedure. You really want a long-acting preparation.
Right.
Why must you absolutely avoid bupivacaine? This forces them to actively engage with the drug's specific pharmacokinetics.
Because they have to solve the problem for the kid.
Right. And then you explain the mechanism. Bupivacaine binds incredibly tightly to cardiac sodium channels and disassociates very slowly.
And in a small pediatric body with a fast-beating heart?
That tight binding means the drug accumulates on the sodium channels during diastole. This is why, in children, profound cardiotoxicity and fatal arrhythmias can manifest before the brain even shows the classic neurological warning signs of toxicity.
Wow.
You aren't dumbing down the science at all. You're just putting the patient first.
Yeah, if the listener who submitted this is worried that removing tables means simplifying the lecture, they really shouldn't be. You aren't removing the heavy scientific data, you're just changing the sequence of how it's revealed.
Exactly.
Let's look closely at the section discussing the calculation of maximum safe single doses. Because once you've used a case study to pick the right drug, the next immediate hurdle is making sure you don't give a lethal amount of it.
The section detailing maximum safe dosages relies too heavily on static worked examples, which misses a critical opportunity to build practical clinical confidence.
See, I have to play devil's advocate again here.
Go for it.
Because when I read through this submission, the math in figure 13.15 looked flawless to me. The author provides a perfectly accurate step-by-step mathematical breakdown for a 70-kilogram adult requiring lidocaine 2% with adrenaline.
Yes, it is accurate.
It shows the 7 milligrams per kilogram rule, calculating out to 490 milligrams, dividing by the 20 milligrams per milliliter concentration, and arriving precisely at 24.5 milliliters or 11 standard dental cartridges. I mean, it's perfectly correct. What exactly is the weakness here, if the math is undeniably accurate?
The weakness is human psychology. Presenting this mathematical breakdown passively allows the audience's attention to drift precisely during the most critical safety checkpoint of the entire lecture.
Just because it's math?
Well, I guarantee you, if a lecturer puts a wall of flawless math on a slide and just talks through it step by step, the audience instantly checks out. I mean, I'm sure we all have PTSD from university lectures where a professor threw up a slide with 40 numbers on it and just kept talking.
Yeah, totally.
The brain's natural defense mechanism is to say, oh, I'll just take a photo of this slide or refer back to the handbook if I ever need to do this.
Right.
But calculating maximum dosages isn't something you can just passively absorb and hope to recall during a stressful clinical moment.
It's like calculating fuel for a flight. You can't just memorize a static chart because wind, weight changes here. The patient's weight, age, and tissue vascularity are the variables that determine if you crash.
That is a brilliant way to conceptualize it, and it perfectly sets up the suggestion here.
Okay.
From a passive showcase of the author's math skills into an interactive, step-by-step problem-solving exercise for the audience, you have to make the math active.
So how do we actually execute that in the room? Walk me through a concrete example of making this active.
You start by providing the audience with a high-stakes scenario. Imagine a slide that simply says, you are treating a 20-kilogram child who needs articaine 4% with adrenaline 1,100,000. What is your absolute maximum volume?
Okay.
And then, crucially, you stop talking.
Oh.
Don't give them the answer. Force the audience to pull out their phones, open their calculator apps, and actually perform the math right there.
So you literally let them struggle in the silence for a minute?
Yes. You let them wrestle with the 7 milligram per kilogram rule. They have to realize on their own that 20 kilograms times 7 milligrams gives a maximum absolute dose of 140 milligrams.
Right.
Then they have to remember how to convert a percentage into a concentration. They have to know that a 4% solution translates to 40 milligrams per milliliter.
Which is not intuitive if you haven't done it recently.
Exactly. Finally, they divide 140 by 40 to reveal the absolute limit of 3.5 milliliters. When they arrive at that number themselves, the neural pathway is forged in a way that simply watching you do it will never achieve.
And the material actually provides a really stark contrast to highlight why doing this math matters. Table 13.9 shows the approximate maximum volumes for both a 70-kilogram adult and a 20-kilogram child side by side.
Exactly. And that is where the lecturer needs to drive the point home visually to maximize the impact.
Like putting them next to each other?
Yes. Once the audience calculates that 3.5 milliliter limit for the child, the lecturer should advance to a slide showing what happens if they accidentally default to the adult volume of 12.25 milliliters for that exact same drug.
Wow.
The visual disparity between 3.5 and 12.25 is terrifying in a clinical context. It visually represents a massive overdose.
That's a huge difference.
By making them do the math themselves, you are simulating the cognitive load they will experience in the clinic. If they only ever see that 70-kilogram adult example on a slide, they might unconsciously anchor on that 11 cartridge limit.
Which, as we discussed with the airplane payload, could be fatal if misapplied to a smaller body.
Precisely.
It's all about shifting the burden of effort from the teacher. Let's move on to the final major section. As I understand it from the notes, the argument here is that clinicians must be equally prepared for a wide spectrum of adverse effects.
Because even if you pick the right drug and calculate the perfect dose, human biology is unpredictable.
Right.
The presentation of adverse effects currently treats all complications with equal narrative weight, which blurs the line between common clinical hurdles and rare medical emergencies.
Yeah. This is a massive structural and tonal weakness that jumps out immediately. I mean, the document lists local neurological complications, things like temporary facial nerve paralysis, transient paresthesia, and trismus, right alongside severe systemic toxicity and life-threatening conditions like methemoglobinemia.
Right.
Because it's written in a very neutral, objective, academic tone. There's no escalation. Everything feels like it's on the exact same level of severity. For a learner, this makes it incredibly difficult to mentally prioritize their emergency responses.
That flat tone is dangerous in an educational setting.
Really?
Oh, yeah. If you deliver the lecture in that same steady voice, reading bullet point after bullet point, a student might walk away subconsciously thinking that a patient experiencing prolonged numbness requires the same level of adrenaline pumping panic as a patient experiencing cardiovascular collapse.
That's a great point.
The suggestion here is to group and escalate the adverse effects by required clinical triage action. The lecturer needs to create a clear first aid framework that actively shifts the tone of the room from calm reassurance to urgent emergency management.
I love the idea of using vocal tone as an educational tool. Let's build some concrete examples from the text to establish that escalation.
Sure.
You could start this section of the lecture with the common, highly manageable issues. For instance, talk about complete or partial failure of the local anesthetic.
Right.
The clinical action there is simple reassess the anatomy, review the injection technique, and potentially repeat the injection if you haven't hit the maximum dose. It's a low-stress situation. Your tone should be breezy and matter-of-fact.
Then you step it up slightly to local complications. You talk about temporary facial nerve paralysis, perhaps from an injection that accidentally affected the periocular muscles, or, prolonged anesthesia.
Okay, so a bit more serious, but not an emergency.
Exactly. The clinical protocol here, as the text notes, is reassurance and observation. You tell the student, keep the patient calm, monitor them, and if sensation hasn't improved after 3 months, consider a MaxFax, a maxillofacial referral to look for potential structural nerve damage.
Right.
The tone of your voice as a lecturer here should be steady, comforting, and analytical. You are literally modeling for the students how they should sound when trying to de-escalate a nervous patient.
But then you execute a sharp pivot. You completely change the atmosphere in the room.
Yes. This is where you drop the comforting tone entirely to address red flag emergencies. You move into systemic toxicity. You describe the early indicators with urgency, restlessness, anxiety, tinnitus, dizziness, tremors.
bringing back that pharmacology from earlier.
Exactly. Emphasizing that with a drug like bupivacaine, cardiovascular arrhythmias might actually occur before any of these central nervous system effects show up. And then you hit them with the most dramatic hook in this material, methemoglobinemia.
Yeah. The material describes the most distinctive clinical feature of methemoglobinemia as slate gray or blue skin, lips, and nail beds. I mean, that is an incredibly striking, terrifying visual.
You use that visual to completely command the room. You don't just list the symptom. You explain the suffocating mechanism behind it.
Okay.
You explain that certain drugs can oxidize the iron in hemoglobin from its normal ferrous state to a ferric state, creating methemoglobin. And this altered molecule is completely incapable of binding oxygen.
Wow.
So you tell the audience your patient is sitting in the chair, breathing normally, but they are essentially suffocating from the inside out because their blood can no longer transport oxygen to their tissues. That is why they are turning slate gray.
That will definitely wake up anyone sleeping in the back row.
And you use that intense urgency to discuss the genetic variables. You explain G6PD deficiency, an inherited enzyme deficiency that normally protects red blood cells from oxidative stress.
Right.
If a patient lacks this enzyme, their red blood cells break down prematurely when exposed to certain triggers. You hammer home the absolute rule that prilocaine doses must be strictly monitored, especially past the 600 milligram threshold because of its specific potent link to inducing this exact oxidative stress.
I can see what you're going for here. Let's see how we can strengthen this. Is there a risk that emphasizing rare, life-threatening events like methemoglobinemia might make new practitioners overly fearful of using standard effective drugs like prilocaine?
That's fascinating. What are the potential limitations or counter-arguments to that idea?
Well, if you scare them too much with images of slate gray, suffocating patients, they might just avoid the drug entirely. Even when prilocaine with fullepressant is undeniably the safest option, like in our pregnant patient scenario earlier.
The risk of creating paralyzing fear is definitely real, which is why the tone must balance urgency with statistical reality. The lecturer has to frame these severe safety protocols not as reasons to avoid the drug, but as empowering, protective knowledge.
Making them feel capable, not just scared.
Exactly. You look at the audience and tell them, prilocaine is an incredibly effective, indispensable tool in your kit, and you can use it with absolute confidence precisely because you now know to respect that 600 milligram boundary.
Yeah.
You teach them that understanding the extreme, absolute limits of a drug's safety profile is exactly what gives them the freedom and confidence to operate dynamically within those boundaries.
That framing is crucial. It turns a scary warning into a badge of clinical competence. By restructuring the lecture this way, moving from static reference data to dynamic clinical application, the author can completely transform the audience's experience.
Yeah, absolutely.
Let's do a quick recap of our core actionable takeaways for the listener who submitted this. First, reorganize your anesthetic choices around patient case studies rather than duration categories to create an immediate clinical hook.
Right.
Second, transform those dosage calculations from passive, read-along examples into active audience problem-solving, forcing the room to confront the severe physiological differences between adults and children in real time. And third, restructure the adverse effects into an escalating triage framework, utilizing your tone of voice to clearly differentiate between routine complications requiring reassurance and severe, systemic emergencies requiring immediate, life-saving intervention.
Implementing these structural shifts will take this incredibly thoroughly researched material from a dense textbook chapter to a truly memorable, life-saving educational experience.
We'd warmly invite the author to apply these pedagogical strategies, build out those interactive slide concepts, and submit the revised lecture notes back to us for a follow-up critique. Because ultimately, teaching medical science shouldn't feel like reading a static chart in an empty room. Just like calculating that pre-flight fuel, every variable matters. Every biological condition shifts, and it is the practitioner's active, engaged judgment that determines whether you land safely.